You know, I think one more comment. I actually think you have to figure out which population you have to treat. Because I looked at the Texas law, that was part of my talk, which I won't be giving because of time. They included diabetic patients in there, which is stupid. I think diabetic patients don't need to be screened. They need maximum medical therapy.
Well, I wish Dan was here. I wish Dan was here.
That's fine, but you know, there's no organization that currently doesn't suggest that patients with diabetes are not at coronary heart disease risk equivalency.
But they're not, and that's based on population. But 40% of patients in Mesa had a 0 score that were diabetic. So if you don't have access to good tools, then you use the population.
Yeah, but if you're practicing, but no, what I'm trying to say is where what we're doing needs to fit in is here. We already know who needs treatment, right? The risk of the group of people that will currently be given drugs are those who are at intermediate risk and have some other thing that puts them above, right? So the best one the one that's moved the farthest so far is CRP. And they've done a trial where, we're not talking about screening, but if you had a CRP above 2 and you were in the right age group and you were treated, then your event rate went from 1.35% per year down to 0.77% per year. So now, since that is the first one out of the barn, the tests that are being talked about today need to show us that if you have a CRP under 2, and you're at intermediate risk, so FRS under 20, and your LDL's under 160, then you would have some benefit from being treated with a statin, and that is what has to be done so that you get sign-off from everybody that it's obvious and should be done. But at this point, there is no evidence to suggest that you can, in an unselected population at intermediate risk of all comers, do the test and then treat them and then see that there are good outcomes. And if you want to convince someone like me that I should send someone for a coronary calcium score, then you have to show me that in an unselected intermediate risk population who I just described, they get benefit from treatment.
Just to present the opposite point of view, I think if you did that trial and showed that they did not benefit from treatment, it would be the fault of the treatment, which is not to say that you shouldn't identify those who were at high risk. If we can't improve their outcomes, we're doing something wrong with the treatment. And to not identify these patients is a form of therapeutic nihilism.
Yeah. So I think what you, Josh, this is your last slide, right?
Yeah.
So this is what your point is. That I think we'll come back to what you initially brought up, and that is, do we give aggressive treatment and do we give maximum treatment at the beginning? There has been several opposing, views that we don't, and we need to be able to titrate our therapy.
Yeah, but it's the same thing where we think it's going to work. But look, when we tried to lower blood pressure to lower than 120, it didn't work. We know that when we added ferulic acid derivatives to diabetics above statins, it didn't work. And so the idea that you can intensify therapy and make people better is as much a supposition as that you can do screening and identify people who need treatment and will benefit from it within that spectrum.
Okay, so as a follow-up to that question, do you have programs in place? And as Dr. Fuster pointed out very rightly, that let's just do this experiment in Texas, show that screening does make a difference in outcome. What do you have in place to actually make that happen before this thing can be?
Yeah, we're trying to build another statewide legislation or not legislation support to do monitoring at the state level. Basically, this bill will be adopted, but we have some issues in the adoption, and that is who does the test and where the test is reimbursed. Our goal is not just to provide this opportunity for increasing income at 5 or 10 or 30 big hospitals. That's not going to make a difference in the primary prevention. We want to be able to have that in the doctor's office, in the primary care physician's office, and that's more some of the issues that you're facing this. But beyond that, if we address that, which is being addressed by Texas Department of Insurance and ICABEL, and we'll be working with them as well through SHAPE, we will be implementing monitoring tools. So in a year, 2 years, we will look back and see how we've done, and that's really the best marker to go and talk with the national societies and so on. I'd like to terminate our meeting with Erling's slides. Erling is pathology, so it brings a significant amount of insight from a pathologist point of view. What's the connection between carotid and coronary? And yeah, you can sit here. Just